Good afternoon and welcome everyone. My name is Juan Carlos Julián, General Manager of the Spanish Kidney Patient Federation, Action Plan responsible at the European Kidney Patient Federation, and research in the field of methodology in health psychology at Universidad Autónoma de Madrid in Spain. With me, two medical experts, two world-class experts, Professor Peter Rossi, diabetologist and head of complication research at Steno Diabetes Center of Copenhagen, Denmark, and Professor Christoph Warner, nephrologist and professor of medicine at head of the division of nephrology in the Department of Medicine at the University Hospital of Wartburg, Germany. Good afternoon, professors.
Thank you. Hello.
Hello. I'm really excited to start this interesting discussion that we are going to have around the report entitled The Realities of Living with Chronic Kidney Disease. People with chronic kidney disease and type 2 diabetes speak up. And today we will discuss the findings of that study and explore why they mean for the clinical community. The survey and the report was developed by the European Kidney Patient Federation in partnership with Bayer AG. In fact, it's the first comprehensive look at patient experience from the diagnosis to the impact of chronic kidney disease and its progression across Europe, based on the experiences of 500 patients with chronic kidney disease and type 2 diabetes in different stages of chronic kidney disease. In 5 countries, Germany, France, UK, Italy, and Spain. In fact, 100 surveyed for each country. I would like to point out at the end of the discussion, will be an opportunity to ask directly Professor Rossi, Professor Banner, and myself question that what's been discussed or anything else related to the experience of living with chronic kidney disease and type 2 diabetes. If anyone from the audience has a question during the discussion, please ask them via the chat function, and they will address it during the question and answer section. Well, go. Let's go it. The first topic that I would like to introduce goes around the speed of diagnosis and in its impact on everyday life of the patient. One of the findings of the study that concerns significantly is that 9 out of 10 of respondents experiencing symptoms before 2 months the diagnosis. But almost 40% were experiencing symptoms for more than 6 months, and that fact for 25% it was in fact for more than a year. Well, so Professor Garner, could you explain why this is a cause for concerns?
So your signs and symptoms, what you maybe are telling us is more tiredness, less energy, and this happens to all of us during our life in many instances. And you don't think that kidney disease when you are a little bit less energy and tired, yeah? But in essence, kidney disease, the kidneys do not cause pain. It's a silent disease, yeah. And the only thing is, when you have type 2 diabetes, which is very frequent in the elderly, around 60 years of age, you have to be aware that the kidneys can become problems over time. So you need to have the kidneys tested. A silent disease, you have no pain, a little bit tiredness, yes.
And then, Professor Warner, what would be the key reason that type 2 diabetes patients are not diagnosed sooner, in your opinion?
So usually type 2 diabetes causes over time a lot of problems, and the doctor has to talk about many things. And the kidney requires a test, a blood test and a urine test. And you need these 2 tests to diagnose and understand the kidney disease. Yeah? And this over time every doctor should do this kidney test. Also, every guideline on the world is talking about this, but finally, to have this test done, this is the problem. Not every patient, not everybody with type 2 diabetes gets this test on an annual basis, and this is required.
Okay. And Professor Rosen, are you surprised by these findings? Could it be that many doctors are not doing kidney function tests more regularly?
Well, unfortunately, I think these data just support what we have seen in many other evaluations of testing for kidney disease, that we tend to remember to test kidney function, or eGFR, the blood test that Professor Werner was talking about, but the urine test, the albuminuria, the kidney damage test is often lacking, and at least we tend to forget. And maybe it's because there are so many things, as we heard. You need to think about the eyes, the blood pressure, the glucose level, body weight, lifestyle, and so on. And then you also need to remember the kidneys and check for kidney disease. And sometimes that is forgotten because it may be a little bit complicated to remember this urine test, or you forgot at home and so on. But we really need to implement that. This is super important. Maybe there was also a reflection that maybe it doesn't make a difference to test, because what can we do? We are already treating blood pressure and there's no more to do. But I think we have seen that there's a lot more we can do, and recent years have taught us and given us a lot of opportunities. So therefore, it's really important now that we can change prognosis if we test and screen. So we need to change these numbers.
Yeah, and in this situation, regarding your colleagues, what you will encourage your fellow clinicians to do?
Yeah, I think it is important to work in a systematic way and try to organize how you deal with care of these patients, so that you have a regular screening system, that you, in your way of seeing these people with diabetes, have a regular screening procedure. Every year you do these tests of blood and urine and check for kidney disease, as well as the other things you need to check for. That has to be put into a system. You need either nurses or lab technicians to help the physician make this happen on a regular basis. And then I think it's important if systems or the physician monitor what's going on and report on how it's going, because as we heard, there are guidelines telling us we need to do this, but if we don't monitor if we are actually doing it, we may think we are doing okay, but we don't actually know. But then when we test or check, we find out that, well, we actually forgot in some of the patients, or in many people with diabetes forgot it. So in Denmark, we have a national surveillance, and many countries do have that, where you can see, okay, we report every year how many people had their urine tested, how many had their kidney function tested, and nobody wants to be in the bottom of this ranking list. So I think that also helps.
Definitely, Dr. Rosen, early diagnosis, and Dr. Manner, is a key question, even for kidney patients, because early diagnosis is a better issue for all of us. The second topic that I would like to introduce, and that our survey also demonstrated, is a real lack of knowledge about chronic kidney disease and type 2 diabetes patients before their diagnosis. And that despite the no link between chronic kidney disease and type 2 diabetes, more than a half of those surveyed in our study knew nothing about chronic kidney disease at that stage. Professor Werner, what this should be a concern again, in this case for nephrologists?
You need to know that this kidney disease develops over a period of 20 years. 20 years, yeah. Not everybody gets kidney disease. 4 out of 10 people have to concern about. So 20 years is a long period of time, and then you develop other problems. Yeah, doctors talk in the beginning about don't eat too much, don't drink, stop smoking, and finally somebody is coming now with the kidney test, and very often patients push the diagnosis of kidney disease away because everybody knows in the background there is dialysis. Yeah, I have to go to a nephrologist. He has a dialysis center, and this is what I do not want. Yeah, and therefore I push this away. And often doctors talk about it, but patient tells you later on, I've never heard about it. Yeah, so this is the entire environment. We have to think after a certain period of time and then test of annual intervals. I think this is and structured and in a program and structured way, as Peter Rossing already told us. Thank you.
Yes, of course. Despite, as I said, despite the no link between the two conditions, between chronic kidney disease and type 2 diabetes, Dr. Rossing, why do you think that many patients with type 2 diabetes don't have a better understanding of chronic kidney disease, perhaps their perception of risk about it?
Yeah, I think as we heard, it's a balance between, on one hand, you would like in the beginning to talk about the disease and you talk about lifestyle, you talk about how you can modify your lifestyle to improve outcome. And you hope that you will not be one of these 40% that are going to develop kidney disease, and you focus on hopefully doing good on lifestyle intervention and the medication and thereby avoiding all the complications. And then you don't want to discuss them because, as we heard, it's not nice to if you early on start thinking about you will end up in dialysis and that all the problems related to that, or you think about becoming blind or developing a need for amputation. So there are a lot of concerns you may have. On the other hand, if you start very early to talk about that diabetes is a disease that if you don't control it and you don't manage well, you may end up with all these problems. But if we manage well, then we can avoid them. Then you can say, then you explain the risk and also try to motivate to get into regular screening so that we can stop or prevent these complications as good as possible. And recently we had a discussion with some people we had followed for many years and tried to say, how would you like care to be different, or what should we have improved for coming people with diabetes? And we got the feedback that I would have liked to hear earlier about my disease and the risk for complications. And that was a person now in dialysis with a myocardial infarction and also an amputation of one of his legs, that was saying, okay, I didn't take it serious for many, many years because I was not aware of the risk I was running. If somebody had told me that, I would have liked to know, and then I would have been able to modify or change my behavior much more. But it is a balance. You don't want to scare people away and get them completely depressed of having this diagnosis of diabetes and early on trying to talk about all the complications that can come. But on the other hand, people need to understand that there are some potential consequences, and it's much, much easier to intervene and prevent early on in the stage of disease before the complications are there than trying to repair when you are on the stage or close to needing dialysis. So we need to talk about this early on, but we also need to find a balance between keeping people motivated and engaged and trying to adhere to these different lifestyle changes, medications, and regular screening intervals. They need to understand that the symptoms of all these complications are not there. They are silent, as we heard. So most complications, they come sneaking over many, many years. But we have an opportunity, if we screen, to detect them and to be more aggressive in our treatment and optimize the prognosis.
So Juan Carlos, can I give a comment about this? Because what Peter said is very important. A week ago, we had the World Kidney Day. And out of a sudden, I learned that Tina Turner, the singer, you may know Tina Turner, she made a campaign and was exactly telling the world, please give me a little bit more education. I had such a high blood pressure. I didn't take it seriously. And out of a sudden, my kidney failed. Yeah? She had to go to dialysis. She became a transplant and is now back to dialysis at her old age. But she is telling the story. And if you go to the internet, you see her campaign everywhere. It was a great story, exactly telling, give me a little bit more information and education, and then you have to take it seriously. Thank you.
Of course, Professor Wanner, very good remark. Of course, the worsening in a celebrity can help us a lot to raise awareness about what happened with this kind of diseases in patient and risk, like Tina Turner. I absolutely agree, and to be honest, this finding I surprised me, because despite the no link between chronic kidney disease and diabetes, and the great impact that that patients suffer when start, especially dialysis, I think we need to do more in this way. Thank you both. The third topic that I want to introduce and present is in addition to the direct implication for health and the high impact of chronic kidney disease on everyday life, and this detrimental, including mental health impact, financial burden. There are a lot of questions that impact in the life of patients. They affect the relationship, the intimacy. But for today discussions, we are going to focus on mental health. We have to focus the discussion on mental health and the impact of chronic kidney disease on health of the responders seems devastating. Where 7 out of 10 responders say that they experienced anxiety around managing their chronic kidney disease, and almost 60% say that they have experienced depression since their diagnosis. This is really important because of the great impact of anxiety and depression on the person's quality of life. One of the questions more important. For this reason, Professor Wanner, why do you think these figures as high as they are? And what it is about chronic kidney disease that has such a devastating impact?
So I think everybody who gets the diagnosis of kidney disease and understands it and looks into the internet, at the end, you see the devil dialysis at the end, and you don't want to go into dialysis. Yeah? And this makes you a little bit fear of it, and you push it away. On the other hand, you see that one problem can come after the other with cardiovascular, the heart, and brain function. And you see that you also are aging on an accelerated way. Maybe you have heard about that you lose life expectancy. This is far away. Nobody wants to hear about this, and this causes not a really depression, but and sometimes you see also that cognitive dysfunction is coming into. You forget, and you understand this, and this makes a patient to fear about the progression and what the future is. This is my interpretation.
Thank you. Professor Rossin, is there anything else that can be done within the clinical community to support patients with their mental health?
Yeah, I think, first of all, I think it's important that we educate about both the risk but also about the opportunities we have to mitigate this risk, that there are improvements, and that we have seen over the years with the new opportunities that we can improve prognosis. So maybe you have, when you are diagnosed with diabetes, you know somebody that ended up in dialysis, but we also know that we now have better opportunities today that we had 20 or 10 or 30 years ago. So the risk is still there, but it is reduced if we intervene and act. So I hope by providing the message that there are problems or opportunities for intervention, we can relieve some of this anxiety. But then we, of course, also need to talk about it and talk about that fears. And in some instances, it may even be necessary to provide help with a psychologist to talk about the concern of what can come. But I think it's important to start a dialogue with your healthcare professional about this and be open about your concerns, but also to from our side, provide realistic information about how we can together try to reduce the risks that we have seen in the past.
Yes, Professor Rosin. I know one professor of medicine in Spain that usually said is a professor of primary care that everything say that at least 50% of the treatment is to ask your patient about how they feel. This is a really important question, but everything is linked, Professor Rosin and Professor Warner. If you cannot prevent chronic kidney disease, if you can diagnose kidney patient early, you can also prevent bad mental health and to prevent emotional disorders, of course. But Professor Warner, what action you take when concerned about a patient mental health well-being?
I usually talk and invite relatives, yeah, and try to find out how the patient is embedded within the family and what support structures are out there, and that the family is understanding the situation. It is not always that the patient has only 20% kidney function, which is a little bit more worrisome. If you have 50% kidney function, for example, and this you can easily measure by this blood test, glomerular filtration rate, 50 ml per minute per year per minute is 50% kidney function. So try to take this anxiety away, give him hope, and there is still a lot to do, and you can stop the disease and show him the possibilities, yeah, in a positive way. This sometimes helps more than another pill against depression, yeah? And then try to give him support that he can understand and manage this anxiety within the family. This is usually my approach, and this helps more. I understand that in severe cases, Peter was talking about the psychology, yeah. Yes, sometimes, but the environment is usually more important, especially when the patient is elderly. Yeah? Many people are 17, 80 years and above this age. Yeah? And so here the family plays a very important role. Thank you.
Thank you, Professor Warner. Today we have people from all around the world, not only from Europe, but I think the three topics that our report shown are three topics that can extend to other countries in the world. I think it's the common problem, I'm sure, not only in Europe, even worldwide. What's your opinion about it? Perhaps these topics are similar in other countries or specific to the situation that we have in Europe, for instance. Whatever you want. Professor Warner?
It is very similar everywhere, I think. Yeah. Today, I I realize, and I got the notice that here within LinkedIn, 40 countries are listening. I see that many people across the world are here, and I think the basic principles are all the same: avoiding the disease, taking fear away, and try to intervene when possible early. And the management at the final end is different and depends also on resources in the country. But lifestyle, for example, and all other approaches, basic medication, blood pressure, and comorbidities avoiding is pretty similar. I don't know what Peter is thinking. This is my impression at first glance.
No, I think on one hand, it's important that we need to manage diabetes and kidney disease in a local context, because dietary habits are different and treatment organization is different in different settings. But the basic problems are the same. This is a silent condition. We are not screening for it. We are not intervening early enough, and therefore we are missing the opportunity for intervention, and that is a global problem. We can see in some systems where they have organized care very well that it's possible to screen and intervene more early and more optimal. But unfortunately, for the majority of places all over the globe, we have the same issue that people are not screened for many different reasons, probably. But I think, and therefore the solutions may also be different in different contexts. What works in one setting may not necessarily work in the other setting. But the first step is becoming aware of this lack of screening, lack of diagnosis, and lack of intervention, the many opportunities that we are not necessarily applying. And if you are aware of your problem, then you can start solving the problem and finding solutions, testing out if they work, and then implement treatments or try new things if the first things are not working. So first, we need to be aware that we have an opportunity if we diagnose more and if we educate people more about this. And I think also one thing in relation to education is education about the disease, but also education about the need for screening. If people with a disease are aware that they need to have their blood pressure measured, their kidney function, their kidney damage, if that has to be tested regularly, they are very good at telling their doctor, hey, didn't you forget to measure my urine? Didn't you forget to look me into the eyes, and so on? So if people with the disease or at risk for the disease are aware, I think that's also an important step. So hopefully this and other initiatives can help to spread this awareness and make people aware that they need to be tested. I know, for instance, many diabetes organizations are trying to educate their members with diabetes. Hey, you have the almost right to be tested for these issues on a regular basis, so we can capture the complications as early as possible and intervene.
In this line, Professor Warner, to raise awareness about chronic kidney disease, about the importance of early diagnosis. Yesterday, I was talking with a colleague from Spain, Alberto Ortiz. I'm sure you meet him because as your role as past president of the European Renal Association. And he told me that, for instance, cardiologists has the ABCDE of more important factors to prevent cardiological problems. And he told me, why not ABCDE to prevent chronic kidney disease? And said me, A from albuminuria, and E, for instance, for estimated glomerular filtration rate. What does mean? We haven't spoken about these two tests. Could you explain why both are required?
So this ABCD is a new concept, and I like it. And the best thing would be when a patient one day is coming to me and say, doctor, what is my ABCDE? So B is blood pressure, C is cholesterol, cholesterol and these diabetes, everything we have normally under observation, and A is albuminuria, and E is kidney function, is glomerular filtration rate. So on an annual basis, if I have this in overview, then I can tell you exactly what to think about, where to take care, and how the entire thing is going. And you say cardiologists have now discovered this. Yes, they have now in their guidelines the A, B, C, D, E, because they see from the A, albuminuria, and from the E, kidney function, they see cardiovascular health. It's a mirror into the cardiovascular system. And for early detection of heart problems, heart attacks, heart failure, they use now these tests. And I'm very happy that we nephrologists get now a wind from the back, and maybe endocrinologists, diabetologists also appreciate this, that a larger communities of specialists and doctors are now looking into these early testing, and that we do not have to discuss the later phase. This was a good example. Thank you, Juan.
Yeah, and if I can add, I think it's super good and super important also that this is not for the nephrologists only. We need everybody to be engaged in this, the cardiologist, the diabetologist, and most of all the general practitioner, because the general practitioners are those, or the family physicians, they are the ones seeing the majority of people with diabetes, and they are the ones that need or have the opportunity of early detection of these complications. When we are reaching the nephrologist, that's usually quite late, a quite advanced disease. If we're doing a good job, we are observing it and diagnosing it much earlier and trying to intervene much earlier.
Okay. So please, all colleagues out there, not nephrologists, help us, help the patients to find out what happens with the kidney early on. So this is my...
Okay, Professor, we have a question from the audience. The first said, can we also discuss one of these more significant treatment options, the kidney transplant, and the challenge regarding the approach as well as the methods to mitigate against this? Is more a comment.
Yeah, I can say that when I tell my patients it's not so problematic, life is not over, we have other opportunities, we have dialysis, you are young enough, we can put you on the transplant list, do you have a living donation from one of your relatives? This is not a solution for the patient. This is an opportunity out there. There is hope. You can continue, but we need to intervene earlier. Patient does not want to see these difficult but life-saving treatments at the end. We can offer something, yes, but I want to go into much earlier phases of life and have awareness about it.
Yeah, from our point of view, Professor Gunnar, the most important as a kidney patient organization is to prevent chronic kidney disease. But if you end in renal replacement therapy, we have to provide the best quality of life as possible. But regarding early stage, Professor Rosing, what will be your advice to help patients as they come to terms with their diagnosis?
Well, to come to terms with the diagnosis, you mean of kidney disease as a complication to diabetes? I think if we are in the early stage, I think the opportunity is to provide the message that there are lots of things we can do lifestyle-wise. There are things that are general for type 2 diabetes that can be reinforced when you have kidney disease with a healthy diet and with exercise. So there are things you can do yourself. but there are also interventions that we can provide and we can offer, treatments that can stop or delay progression of disease. And the earlier we identify the disease, as we also heard before from Professor Wanner, the better the opportunities of stopping this disease or the complication, so that dialysis will never be necessary, that transplantation considerations will never be relevant, because you can easily survive with let's say, moderate impaired kidney function. That will not be necessarily an issue. You may have a higher cardiovascular risk in that situation, and therefore you need to be aware also of your cardiovascular risk factors, like cholesterol, as we discussed before, or like if you're smoking and so on. So in that sense, it is important to be aware not just of the kidney, but also of cardiovascular risk in these people. But I think the good message and the how you come to terms with this is that there's a lot you can do, and there's a lot we can do together to prevent this from becoming a very serious problem.
We have comments from the audience. One of them is about the question of educating people about the basic and the warning signs that are important in case there is a delay in diagnosis. This is a place to say your inputs, regards, news from India. It's a person from India. Yes, I think it's a very important point, how we can detect chronic kidney disease for people in risk, for people with type 2 diabetes. Because one of the problems is that when you feel symptoms, usually it's too late.
Exactly. I think we should not educate people about the symptoms they should be looking for. We need to educate people that we need to test, we need to do the screening, as we heard about before, because if we do not measure albuminuria and eGFR or kidney function, then we do not know how the kidney is doing. When we can feel the kidney is not doing well, then we are too late, almost at least. So we really need to, the message in the education is, you cannot feel it, we need to test it.
Other comment from the audience is regarding education and regarding the use of application of artificial intelligence to the management, or to use in the management of the chronic kidney disease. What's your opinion about this tool, these possibilities?
I think we could take advantage, if I can start and say, I think we can take advantage of artificial intelligence mining our electronic medical records, helping us to find risk patients. But I think a lot of things we can do without artificial intelligence, but it may help us refine case finding. And it may also help us remind us to do the right treatment in the right time. And it could also perhaps in education help tailoring education for the individual person. And I think right now artificial intelligence is difficult to say, what do you mean with this? But I think we can take advantage of today. Many systems have electronic health records, and they can be used to identify people at risk and make the healthcare professional aware, hey, look out, or the system can tell you, hey, it's more than a year ago we tested urine. Why not test it today? Because it's time for that.
But the artificial intelligence system needs to be fed. At least you need one data set where you can say 60% kidney function and very high protein leaking by the kidney, very high albuminuria. And then the system can tell you you are endangered at a higher level or lower level, and go in parallel, check this and this and this and this. Yeah. So your cardiovascular system, but at least you need these tests once that you can feed the system that gives you more help. Yeah.
No. Finally, we have to detect more in early stage of chronic kidney disease. And regarding, for instance, the patient knowledge. one of the question is, what is it you would like to see that primary care physicians or diabetologists or cardiologists communicate to their patients with type 2 diabetes about chronic kidney disease?
Yeah, you see the primary care physician is often measuring kidney function, and there's a printout from the laboratory is telling you have 50 ml per minute kidney function. The patient doesn't understand this, but the primary care physician can tell the patient you have 50% kidney function. And this is what the patient is understanding. And this should be communicated. 50% is, excuse me, in both kidneys? Yes, in both kidneys, 50%. And then you can say it is worrisome. We also do now the albuminuria test, these simple tests, yeah, easy, not very expensive, can be done in every country. Yeah, and then I tell you, there is still time to act, because if you have less than 10% kidney function, you go into dialysis. Yeah, but between 50 and 10%. There is time where I can intervene. And why we are talking today? We are talking today in this podcast because we have interventions since only 1 or 2 years, very potent intervention. We know that we can help the patient and push dialysis away, or when you come early, even avoid it. Thank you.
Now, it's a very interesting remark, Dr. Warner, that the cost of this kind of test is really cheap. It's one of the most cheapest, but for this reason, it's really important to raise awareness about the importance of this kind of test. And
yeah, and maybe you could add that this test is very cheap, but the treatment dialysis is super expensive. So if we implement the test and if we implement interventions, we can save a very, very expensive treatment, which is also associated with a lot of complications. So it's of course not just about costs, but it's also about costs.
We have another question from the audience. Is related the impact of chronic kidney disease in the life of patients, and the person from the audience said that. We are speaking about the mental health impact on chronic kidney disease, but what other aspect of life can be affect kidney patients? For your experience, Dr. Warner.
So when kidney function progresses, a number of other comorbidities come along. And these comorbidities is cardiovascular system, and people, these other aspects of life which can be affect also nutrition. I see a question now in the chat from nutrition, and eating, drinking, nutrition, and mobility are the most important things for the patient. And as a dietitian, you can counsel the patient of a healthy lifestyle, talk about salt and a healthy diet. And I think this brings away and captures the interest of a patient, because he feels he can intervene here. And of course, he does not like that if you take everything away from him, and stop everything. But I think dietitians are very talented to bring him on this level of healthy lifestyle, engage him, and then you can even treat depression or forms of depression at this moment. So that's my short answer. Yeah.
Yes, linking with your answer, there is a question in the chat from the audience from a dietitian, that he or she asked about how they can do when patients are depressed or undependent on dialysis? It's a very important question because the role of dietitians is very important, not only in people with dialysis. I think before in early stage of chronic kidney disease, and I sure in diabetes.
Dialysis is a complete different form of nutrition. Yeah? You can start by saying eat better, avoid certain nutrients. You move from low protein to more protein, a different form of nutrition. I think dietary counseling is very important, takes some time, and resources are low. So I do not know from where the country is coming. Some countries are very good. Brazil is excellent. Other countries in nutrition. In Germany, we have meanwhile moved more to pharmacological intervention, but I think it's very important.
Thank you, Bob. Well, the time is over. Definitely, we have had a very interesting discussion and very important to improve renal patients, putting into value the results of our survey and report. And thanks so much, clinicians. Thanks so much, professors, again, as well as the audience for joining today. And good evening and have a good day.
Thank you.
Thank you very much.